Welcome, everyone. We're delighted that you could join us for this webinar. I'm Bev Johnson, President and CEO of the Institute for Patient and Family-Centered Care and a PCC board member. IPFCC is committed to sharing information about how primary care practices and health systems are partnering with patient and family advisors in making changes to policies and practices and communicating accurate, understandable, and useful information about COVID-19 to their communities served. With today's webinar, Primary Care's response to COVID-19, hosted by the Primary Care Collaborative. You will hear more about the coronavirus outbreak, its impact on practices, staff, and clinicians, and patients and families as well. You will hear how primary care is responding. Our four speakers today bring diverse perspectives to these issues, spanning primary care capacity, virtual care, and community-based approaches in the midst of COVID-19. Given the great interest in this webinar today, we will extend the session about 10 minutes to give us ample time for many of the questions that you all have sent in ahead of time or that you submit during this webinar today. I'd like to tell you a little more about PCC. It is a nonprofit, multi-stakeholder organization that unifies and engages diverse stakeholders, promotes policies, shares best practices that support growth of high-performing primary care. PCC is a membership organization with over 60 organizations as members committed to the mission of advancing an effective and efficient health system built on a strong foundation of primary care and with authentic partnerships with patients and families. To track the impact of the coronavirus and what's needed to respond, PCC has partnered with the Larry A. Green Center to conduct a weekly survey of primary care clinicians on their responses to the COVID-19 crisis. PCC has received today the findings for the fifth week. I won't be able to share those findings with you yet, but I can let you know that over 2,600 primary care clinicians have responded. Information is gathered in the survey during this crisis, and it's being used to raise the visibility of primary care's role with media and government officials and to inform policy proposals. So this is really important data that's being collected. Results from weeks 1 and through 4, along with free resources, are now already on the PCC website at thepcc.org/COVID. I want to share with you a couple of highlights. That this is the data from the 4th week. 72% of surveyed clinicians say that they have patients who are unable to access telehealth due to no computer or internet access. 72%. Patient mental health is being recognized as a critical need. 54% of the clinicians report that COVID-19 has led to increased numbers of patients with mental or emotional health needs. 58% report the use of used and homemade personal protective equipment, PPE, at their practice. 58% don't have that, all the equipment that they need. And about half of respondents report that COVID-19 is having a severe impact, level 5 on a 5-point scale, on their practice. So important work. We hope you will connect with that survey, participate in it, and use that data in helpful ways. Just a couple of housekeeping details as we go forward with the webinar. All your lines were muted automatically when you joined. We hope that you will use the chat feature to send questions in. Some of you sent them ahead of time, but we hope you will have many questions that our panelists will respond to at the end. And the webinar is being recorded, and both the recording and the slides will be posted within 48 hours on the PCC website. So you can go to www.pcpcc.org to get all of this material and additional resources. So I would like now to introduce this incredible panel that PCC has brought together to discuss these issues related to primary care and COVID-19. There's much more information about them on the website, but very quickly, to preserve all the time for them to share thoughts with you, I'm going to introduce them very briefly. And all four now, and I'll come back at the end when we get to questions. Darilyn Moyer is the Executive Vice President and CEO of the American College of Physicians. She's board certified in both internal medicine and infectious diseases, and currently practices part-time at Temple University Internal Medicine Associates. Darilyn is also the current chair of the board for the Primary Care Collaborative. Mike Tuggy is a clinical professor at the University of Washington School of Medicine and a rural family physician in the Mountain Valley in Winthrop, Washington. He works with practice leaders and organizational leaders in family medicine to develop high-value, advanced primary care payment and practice models. Tong is Chief Medical Officer at Doctor on Demand and Clinical Assistant Professor affiliated at the Stanford University Medical Center. Ian has held several medical leadership roles, including co-medical director of the Arbor Free Clinic and founder of the Health Resource Initiative for Veterans Everywhere, THRIVE, as it's known, at the VA Palo Alto Healthcare System. And our last speaker is April Joy Damian, Associate Director of the Weitzman Institute at the Community Health Center Incorporated, where she supports the development of Weitzman's research team with a strong emphasis on health equity. April Joy has a faculty appointment in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health and was previously Director of Quality Innovation at the National Quality Forum. So it's a pleasure now to turn it over to Darilyn.
Thank you for inviting me. I'm just trying to get control of the slides so that I can advance them. Thank you. As you heard from the introduction, my name is Darilyn Moyer. I'm an infectious diseases physician and internist, and I'm the Executive Vice President and CEO of the American College of Physicians. The American College of Physicians is the world's largest specialty organization for physicians. We have about 159,000 members practicing in the internal medicine space. Internists are about 25% of the practicing workforce in the United States, and we have folks that are taking care of patients on the front lines of primary care in the outpatient setting. Internists comprise the majority of hospitalist physicians in the United States. And of course, the pulmonary critical care physicians are subspecialists in internal medicine. So I entitled my portion Primary Care in the Time of COVID. These are the sorts of things that keep infectious diseases of a certain age, like me, awake at night. I think that when you think about how rapidly this epidemic impacted us, it was really a prescription for a pandemic. And if we think about that, oh, I'm clicking backwards, but it's going forwards. So let me try this again. All right, well, I guess we're just going to have to take control of this back to central. There we go. Let me see. It's working. Okay, thank you. So this was a perfect pandemic prescription. We saw that this is a novel pathogen, and what you need for a pandemic is a pathogen that our immune systems have never been challenged with before, that we have no innate immunity. It has respiratory transmission, which is a very rapid and large amount of transmissibility. And of course, we're learning more and more. And one of the things we learned is that 80% of the folks that have COVID are asymptomatic or mildly symptomatic. It has a long incubation period in contrast to influenza. This one has an incubation period, a median of about 5 days, and up to 50% of people are symptomatic at 5 days. The other 50% may not be symptomatic until 12 to 14 days. And during that whole time, they are transmitting it to those folks around them. It has a long interval between cases. So this what's called the serial interval. And because of that, that makes it even more challenging to do tracing of contacts. It has a high reproductive factor. We don't know yet what it is, but what that means is that it seems like one infected person can transmit it to several people around them. Additionally, we're learning more about the fact that there is prolonged shedding of the virus after somebody clinically improves, which raises the potential for infectiousness even more. There's effective fomite transmission, which means that viable virus that can infect others will stick around on surfaces for quite a while after an infected person has talked or coughed or sneezed those infectious particles out. There also seems to be some transmissibility via airborne transmission, which means that it hangs in the air and doesn't quite fall to the ground immediately, as well as oral fecal transmission. We didn't have a lot of sentinel surveillance going on as the reports emerged out of the Wuhan province in China in January, and we really saw a lack of coordination of the initial response at any level. We also saw an exacerbation of the epidemic by the lack of readily available testing, personal protective equipment shortages which put healthcare workers at risk, as well as patients in those practices, hospitals, clinics, etc., that they were getting seen at. And unfortunately, to date, we have no effective treatment or vaccine. Because this is a novel pathogen, it may actually be a year or more until we have a vaccine available. So never were the principles of the primary care collaborative more relevant around person-centered care that is team-based and collaborative, that is comprehensive and equitable, coordinated and integrated, continuous, accessible, connected. And so when I made up this slide last week, I took a look at the evolution of the epidemic to the pandemic. Since then, we now have over 2 million cases worldwide, with a little bit less than 130,000 deaths. The United States has about 610,000 cases with 26,000 deaths. So it looks like right now, ultimately, we won't know the mortality rate until we get a lot more data, particularly the denominator data. But for right now, the mortality rate is looking to be in the 3 to 5 or 6% range. And so this has implications, obviously, for the entire healthcare system, from outpatient arenas, community health centers, through our hospitals, through our intensive care units, because of the spectrum of disease that folks have. And you know, what people are really saying is that COVID-19 did in 20 days what didn't happen in 20 years in our health system, and revealed not just the cracks, but the chasms in our healthcare system. We really saw rapid responses by practitioners in all of the clinical spaces, particularly in the primary care space, to transition their practices to optimize safe patient care, minimize the risk to patients and their practice colleagues, and try their best to keep people out of the emergency department and the hospital if they did not need that level of care. So the issues of practice transformation, patient care and triage algorithms, digital readiness, connectivity, interconnectivity, protected health information, practice revenue and viability, the lack of personal protective equipment and access to COVID-19 testing, the tsunami of data we were all faced with, the changing regulations around documentation, billing, coding, etc., from national and local authorities was really a tsunami that we all had to deal with. And again, this concern around the lack of coordination amongst local, regional, state, national healthcare organizations. And what we saw was really such good coming from bad, as increasingly we saw disparate groups working together on behalf of our patients. The ACP actually, right at the beginning of the COVID, not timed obviously this way, but ACP has been doing a lot of work in the telehealth arena to get practitioners prepared and up and running. We did a pre-COVID survey that we published in January of 2020, where we took a look at ACP members with technologies that were available. And the green is implemented, the blue is considering. So there are about 50% of the people who answered this survey were general internal medicine specialists practicing in the outpatient setting. 25% were practicing in inpatient medicine in the hospital setting. The other 25% were internal medicine subspecialists. And as you can see, well less than a half of them had actually implemented video visits, e-consults, asynchronous connections, monitoring, management, or wearables prior to COVID. It will be very interesting to see what the results are post-COVID. And so what we saw is that the GIM, general internal medicine specialists practicing in the in outpatient setting, and hospitalists were much more likely to be utilizing these technologies. Remote monitoring and remote care management were both used significantly more often in rural practices. I'm not going to go over what Bev Johnson told you were the top line take homes from the Green Survey, primary care survey, but very concerning is the fact that almost 3/4 of the practitioners said that they have patients who are unable to access telehealth due to no computer or internet, as well as major concerns about lack of PPE, and that about half of the respondents were having severe impact at the level of their practices. The take homes from a large survey of about 138,000 family medicine physicians who support about a little less than 2 million jobs, also demonstrates a lot of concerns about losses potentially of practices because of this rapid transition. And so this survey for PCC helps to recommend policy that we need a transparent, coordinated national effort to make sure we have testing and PPE, and that we need to ensure that not just virtual telemedicine audio visual visits, but that we really need pay parity for practices for audio only telephone calls in their practices, because some patients only have a landline or have a cell phone that does not have smartphone capacity. So this is very complicated. The picture on the left is the telehealth diagram that ACP has supplied our membership with. I also want to note the ACP COVID website, which is a freely accessible, there's no paywall, this is freely available to anyone, and it is a largely, it's both a physician resource hub as a more general resource hub. It also has well over 15 advocacy new policies, positions, and statements that the ACP has put out since the beginning of the COVID epidemic. So rapid transitions like healthcare are very complicated. And this is sort of the complicated diagram, and I'm not going to go through this, but in terms of what all the steps that need to happen to have successful transformation to a telehealth practice. The other thing that I think our practices are gearing up for are the additional waves. This first wave of the immediate mortality and morbidity of COVID, and then of course the wave tail in terms of the recovery for those folks. But the second wave, the impact of resource restriction on urgent non-COVID conditions. We're trying to minimize people using the emergency room, but by all means, if they're having a heart attack, a stroke, etc., they need to still be utilizing the emergency room. The third wave of what will happen with the impact of interrupted care on so many in our population that have chronic conditions. And then, of course, the fourth wave in terms of the long-lasting implications for mental health, for burnout, etc. The ACP put out a series of papers in January of this year, Better is Possible, a vision for the ACP for the US healthcare system, where we had a call to action. We talked about coverage and cost of care, reducing barriers to care and addressing social determinants of health, healthcare payment and delivery system reform. Some have said that this paper was prescient because it really did talk about all we needed to do to be prepared to take care of our entire population, whether on a chronic basis or not. And I think that COVID has also illustrated for so many of us the intersecting epidemics for many underserved patients who have social indicators and social determinants of healthcare who have been disproportionately impacted by COVID-19. I wanted to end by reminding all of you and thanking all of you for all you are doing to step up, to care, to collaborate, to coordinate. I really wanted to also remind you, as Lisa Lightfoot, the mayor of Chicago, when telling the residents of Chicago to practice physical distancing, your jump shot is always going to be weak, stay out of the park. So continuing to emphasize the message around physical distancing is critical. So with that, I'm going to thank you very much and pass it on to Dr. Tuggy.
Great, thank you very much for having me on today, and I'm glad to give an update on what this is doing in rural practice. And I would imagine that many of our other practices that are in rural settings would be able to relate to the situation that we were facing in our part of the world. Going on to the main areas that I wanted to touch on, where first of all, the geography really does matter when you think about how to deliver care in a rural community and how this is impacted by a pandemic. I'll touch on testing, how our appointments have changed, some staff safety and workforce integrity issues that we're facing, and then the role of physicians in community relations as well. And then finally, how the payment model could have been so much better for us in these settings. So first of all, just what we face in our community is that the nearest emergency room to our clinic is an hour away. So we function as an urgent care and chronic and acute care setting for our community. And this really raises some major issues when you look at what can happen to your workforce if the pandemic actually impacts your practice directly. Our travel times to the nearest hospital with ventilators is 2 hours. We have very limited access to care within our communities. In our valley that we live in, we have 2 clinics that have a 50-mile radius of care delivery. So patients do travel quite a ways to get care depending on which clinic they belong to. The other issue is our clinics are relatively small with limited staffing. We have 2 to 3 FTEs of providers at each site. And if you have a limitation of those providers coming into work because of their quarantine, for instance, that really can impact the access to care for our entire community. And then for patient safety, we implemented, pretty much immediately once the pandemic was, becoming more prominent within our state of Washington, we limited visits to any patients who had any URI symptoms. We would not invite them to come into the clinic at all to try to protect our patient population. Testing for us has been problematic. We are still under a restriction to only testing people who have fever, cough, and shortness of breath. We do occasionally bend those rules based on our clinicians' sense about what the patient's risks are, and because of that, we have been able to find some cases of active COVID in our small community just because of being more diligent about who we test. We decided early on to do all of our testing outdoors, and we also had to batch our testing into one time period. So we would have our patients come at 1 o'clock in the afternoon and have one of our staff dressed in PPE go out and test everybody that we could for that day. And then they would take that PPE, tag it, and bag it for the next week, because we recognize that the virus does not survive usually more than 5 days on most any surface. And so we wanted to make sure we were not wasting a PPE setup that we could use later on at a later date if we were running out of supplies. And then the other big problem we had was that many of our tests were not coming back for 10 days. And we had one active case that was a 10-day delay in getting the information back, but we did have the person on quarantine while they were waiting for the test results, fortunately. But that is way too long to really get an assessment of how COVID is spreading in your community. Now, fortunately, we're getting our test results back in under 3 days, and that is making it much more effective. The appointment changes, our organization decided to postpone any annual exams and annual wellness visits, any kind of non-urgent follow-ups. That latter category, though, is always a bit iffy. We know that there are patients who we really needed to check back in on, and so we started doing those as phone visits as much as possible, but occasionally we had to see patients in the office. We're continuing having to do urgent visits on a same-day basis for acute injuries, and so we're still seeing those patients in the clinic. We're being very careful about who we bring in who may be sick. Anybody who has a possible viral infection we see outside on our back porch, in their car, or we've designated one room as our dirty room, which is near our back door, so that we can bring patients in without having to go into the waiting area. As many of you have many elderly patients in your practices, I'm sure you understand the necessity of keeping those people separated from anybody who could potentially have an infectious disease, especially COVID in these times. We are continuing to do some procedures. We do a lot of skin cancer excisions, and so we have not been postponing those. Anybody who needs implantable birth control or any other like IND of an abscess, those type of procedures we continue to do in our clinic without delay. And so we're definitely maintaining that acute and also more urgent care within our clinic in these times right now. For us, as Darilyn mentioned, we've had a huge problem getting patients to actually do video visits. And so we have had to do most of our remote care through phone visits. Fortunately, phone visits work pretty smoothly, but the telehealth visits have been very problematic in getting the connections to happen. So we've really shifted to 90% of our care has become telehealth visits at this point. Although even yesterday, I had about 50% of my patients actually coming in the door. Some refused to do telehealth visits, and so we were having to see them face-to-face in order to meet their care needs. The problem, of course, for us is that our phone visits are getting reimbursed at about $15 per call, even though the call may last 15 to 20 minutes, and that's about a fifth or to an eighth of the reimbursement we would be getting otherwise if we were seeing them within the clinic walls. Patients, of course, love these visits. They think they're great. What they don't recognize is that if we continue to do those visits after this pandemic is over, that our practice would have to close because of lack of financial viability. The other big issue that we face in our clinic was that we have a very small clinic structure, and so basically our distancing within our staff is impossible to do. We were concerned initially that if one of us developed COVID, that all people would be exposed and have to be on a quarantine for 14 days. I mean, recently the guidelines have changed for that, so we could come to work. But the reality is that if one of us did develop active COVID, that we would likely infect the entire team. And we could always hope that that team would be asymptomatic with their infection. But if we had active infection, we would definitely be losing staff who would be unable to work for several weeks, which was going to be a huge problem for us. I mean, there was a possibility of us having to close our practice, which would then leave our community in a significant deficiency of care for the weeks that we would have to be closed. Luckily, within our clinic team, we have no known infections to date. We do have suspicions that some of us may have had COVID that was not very severe, and as soon as the antibody tests are available, we'll be checking our entire staff to see who is immune and who is not. We have had to furlough some of our staff due to low volumes. Usually we're just having them take several hours off a week in order to accommodate the needs that we have in the clinic and still keep paying them as much as we can throughout this crisis. And then finally, working with our community, we have a very active community bulletin board, which is kind of a major outlet for information. And so we've been posting updates on that board online. What's been interesting is reading the other posts that are coming on this board, and there's a lot of conspiracy threads that have been putting out information that we wanted to correct in our online postings, and we were able to work with the bulletin board managers to get that done. And it's been really interesting to see the feedback from our patients. We've had a lot of appreciative comments that they were glad to see that we were actually helping steer those conversations on the bulletin board and providing better information for our community board directly than waiting for the Department of Health. Still to date, the Department of Health has not posted anything on our bulletin board, and it's been very slow to get information out to our community. So we've been able to help accelerate that with that communications. We've also had radio and newspaper articles that have been able to get information out as well. It has been interesting to see, though, the degree of suspicion of the government and the health system as a whole. It's come out with some of these posts that have been propagated on our bulletin board that we have access to, and we have really trying to make sure patients have accurate information about what to expect as far as how to get care and how to manage COVID if they have anybody in their household that's been infected. And finally, I think for us, we recognize that fee-for-service medicine is really not set up to take care of this kind of issue at all. The payment discrepancy between the phone visits and the visits that we do face-to-face is so large that it is not feasible to continue doing those in the long term at all. And it really does push us towards promoting the idea of comprehensive payment for primary care services, which would, had we had patients on a capitated payment plan for primary care, we would be able to deliver care freely without any harm to the practice in any way the patient could receive it. And that's been a major driver for us in our discussions internally about what to push for with our new contracting with our payers that we deal with. And certainly promoting this at a national level would be ideal for primary care to be carved out into a different payment model to allow it to be sustainable. You know, one of the things we would love to be able to do would be able to do even home visits, which would be much safer for our seniors and people who we needed to have eyes on, but we didn't want them to leave their homes or they're too debilitated to leave their homes easily. We have patients post-hospitalization with the recent fractures, things like that, who had difficulty moving, and it would be much better for them to be seen at home. And then finally, the care management piece. We have a care manager nurse who has been making frequent contact with our high-risk patients to make sure that they understand what they should be doing to prevent getting infected. And that person has really been a key person in reaching out to our high-risk population. But yet, without that funding, this would be not sustainable if we didn't have that position already. So I'm going to hand off to Ian Tong, and we'll have him go tell us about his work with Doctor on Demand.
Thanks so much, Mike. Really appreciate that, and I really appreciate all the work that you and your team are doing, and Darilyn also just a great summary. We're grateful to be here. I'm the Chief Medical Officer of Doctor on Demand, and you know, I feel like I have to give two disclaimers. One is that you know, telemedicine may be having a moment. You know, I've had a lot of friends reach out to me saying, "Oh my gosh, this might be amazing for telemedicine." And while it may be a moment for telemedicine, without being overly pious, I do want to say that you know, my dad was a primary care physician. My wife is a county physician executive in the county health system, and so I have mixed emotions about the, you know, what about this transformation. It's a painful transformation. It's a rapid transformation, and so while I am supportive of what this can do for positive transformation in healthcare, I'm also just recognizing that it's painful and very threatening for many of my friends and colleagues who are in the brick and mortar practice and seeing the kind of changes that Mike just described. From Doctor on Demand, I think it's important to give you all, I mean, I realize some of the audience may not have as much exposure to telemedicine and also may not have the awareness of what we do. So if you can think about Doctor on Demand as a 50-state medical practice or national medical practice, if we were brick and mortar, we would be in, you know, you have an office in every state, but we're not in every, you know, we don't have a physical footprint. We're actually virtual. And so because of that, we are sort of more like we are living in the cloud. And so our 50-state solution is ubiquitous, sort of like a net over the entire country. And patients and our exam rooms are where the patients have their connected device, whether that's a phone or a tablet or a computer. And so we have employed our doctors, which is very different than a typical, some of the typical or older telemedicine companies. And I want to point that out, not as a competitive issue, but just for people to understand that there are different varieties of virtual practices. And what I'm going to talk about or say today about Doctor on Demand is in the context of this employed physician practice that are, you know, full-time and part-time virtualists. And also all the visits that I talk about that are doctor visits are visits that have been done on a video platform with video. We have other modalities, which would be phone and text messaging and so on, but that is going to be used primarily with our staff. And it's really used to support the physician visits and the care that happens in between visits. But mostly when I'm talking about doctor visits on our platform or nurse practitioner visits on our platform, it's going to be video that I'm talking about. And some of the data that I'm going to share related to that is all based on video. So I just wanted people to know about that. We really see ourselves as a primary care practice. And so that employed practice is actually able to provide relationship-centered care. That's our approach. And we think that if we're servicing both the doctor and the patient, who are the two most important people in any healthcare interaction, or the care team or other clinician and the patient in that interaction, then we are serving our mission, and we think we're enabling the two most important people in any healthcare interaction. We have a care team that helps with care coordination, so very similar to what Mike was describing in terms of care management and being able to deliver care in between visits. And so we may have some opportunity to say something about that. I'm just going to go ahead and try to advance here. So in 2014, Doctor on Demand was started, and we mainly were looking at mostly urgent care type cases. And that's because for a number of reasons, but really it was an easier way for people to understand and wrap their head around what it is we were doing. We then expanded quickly to other types of care, which included behavioral health, because we saw patients coming to us and we looked at our data and we said, well, gosh, people are coming to us with depression, anxiety. This was noticed, and we were adopted or assigned by various enterprises, large employers, as well as large health plans. And so we really realized that we were building an integrated medical practice. And then we eventually added on a really important piece here after the behavioral health practice, which was we built out our patient profiles and we built out the lab capability. So we integrated with labs. And as we did that, we really realized that we were becoming people's virtual primary care destination anyway. And as we all know, many, larger percentage of our population is really seeking care in non-traditional ways, and maybe not establishing a traditional primary care relationship. And so we are finding ourselves really trying to address the demand from patients and the need from patients to find some other way to access outstanding healthcare, but do so at a distance. And so what this has led to is really the formation now where we are is really virtual health plan designs. And we've done this. There was an announcement early in 2019 that we did with Humana, which is called On Hand. And we also later in 2019, it was announced that we are also doing a care management program, which is really a virtual primary care program for Walmart population in a few states. And so those were all announced nationally. When you think about our practice, so I mentioned the physician practice, and those are an employed group. We also have employed psychologists and psychiatrists. And so all of this care is, again, being delivered virtually. And then we have also non-physician professionals as members of the team who are doing a fantastic job supplementing and complementing that care. And then using the technology platforms, it allows us to do some interesting things with tracking patients, helping the team to be efficient. And the point that I just wanted to make here is that building a practice on these technology platforms allows you to actually link everything together in a way that allows the team to take advantage of synchronous care as well as asynchronous modalities. And by doing so, you can begin to deliver a better experience to patients and actually be able to make this scalable for the patient. I'm going to go ahead and move forward. And I wanted you to just to show you what happens when you begin to do that. So when you put these pieces together and you begin to look at lowering the burden of disease for a patient to have to get to travel that hour that Mike was talking about to get into the clinic, you actually start to really improve people's access. And so what we saw when we looked at our population and we actually looked for patients with high blood pressure, patients with high cholesterol, patients with mental health conditions, as well as patients with diabetes. And so I'm just showing you some data that we had here that really revealed to us what was happening on our platform. We gave doctors the tools and we gave patients the access. And what happened there in the diabetic population or patients living with diabetes was we were actually able to see significant reductions in A1C for patients who had A1Cs above 7, and also for patients who were in the more critically high level of blood glucose levels. And we could see up to a 25% reduction in A1C level, again, just by providing them access. And in some cases, 1 in 3 patients or high percentages of patients were actually to see these significant reductions in treatment to goal. And I'm sparing you all the mental health data, but also really important reductions in PHQ-9 scores on that end. So the point there is that telemedicine was able to really start to deliver effective care and high quality care in our opinion. But it wasn't just our opinion. So when we actually worked with the plans, we didn't realize that they were using data to also analyze us and audit our care. And so this was feedback that we've gotten from multiple plans, national plans, now looking at our care and looking at numerous things, including antibiotic prescribing rates. And they did some comparisons to in-office. They looked at 14-day revisit rates for same diagnosis or across any diagnosis. And so what they saw, there were very similar rates. And this is contrary to a Health Affairs article that was published about 3 years ago that really showed that most of telemedicine was additive. What we saw was actually that it was able to replace certain visits. And so I am not presenting this as to be in competition with brick and mortar practice. I'm actually showing this to those physicians who are contemplating, can they do the same level of care? Can they provide outstanding care for their patients and get the same types of clinical outcomes and maybe even produce cost savings by embracing a telemedicine approach? And I think that the answer really is yes, although this work has not been published. It's third-party data that Doctor on Demand did not produce. It was given to us. A lot of policy changes with COVID-19 have taken place that I think have opened the doors for practices like Mike's to actually begin to take advantage of this. One is the 50-state the licensure requirement. So having an individual license in an individual state has really been lowered and removed in about 50 over 50% of the states. There are abilities now to receive risk adjustment through telemedicine visits. There is, cost sharing has been waived by commercial and public insurers. And then also there's the ability to remove the fee-for-service limitations and same site requirements. And Medicare has taken some of these steps, which I think is really opening the door. And in some cases, I hope this is the reason that we will not go back. I will go ahead just in the interest of time and skip some of the quotes that are here from some of our national leaders. But again, just showing that there's a wide-based adoption of a new way of providing care. Part of the doctor on demand response was really, for COVID-19, was really leveraging our platform. So we created screening tools like a health assessment or a risk assessment for COVID-19 that was compliant with CDC guidelines to make sure that we were able to direct patients and triage them appropriately. So using the platform to do that, but also trying to triage the sickest patients to the front of the line so that we would be able to see the patients that really needed to have a doctor visit virtually. So we did that. All of the reasons for this in terms of being able to slow the spread of the infection, reduce the burden on our healthcare system and the use of PPE, but also keep our vital resource of healthcare professionals safe. These are all very good reasons and things that we realized that we were serving with the rapid evolution of our COVID-19 response and what we were seeing nationally. I just wanted to give this final piece on our physician practice, because in a time when we're seeing high physician burnout, I think this is really important for the members of the American College of Physicians and elsewhere to really think about this. We're seeing a shift in where our workforce may be able to be productive. So physicians, ideally will be able to have a hybrid of an in-office practice, but also be able to leverage the technology and the tools and the infrastructure. They can reach out to their patients across distance and improve access to care. Dr. On Demand was able to bring on board 300 clinicians over the last 30 days, doctors from 20 different specialties, and the average onboarding, getting those doctors active and productive on the platform on average is about 5 days. So I think it's really important to recognize that doctors were able to embrace this technology, and also that doctors are very engaged. We have basically averaged over 95% engagement from our physicians in our Great Places to Work surveys. And so physicians are not only able to do this and able to provide outstanding care, but they actually are thriving, and it's a sustainable way for them to prolong their careers and to be engaged and satisfied in their careers. I think this is really important for our infrastructure, and also especially because usually using a virtual platform can extend care into populations and parts of our communities that typically lack access. And so I'll hand it off to April Joy to tell us a little bit more about what she's seeing there. Thank you.
Great. Thanks, Ian. And thank you all for having me. So as Bev noted in the beginning, I'm April Joy Damian. I'm the Associate Director of the Weitzman Institute, and our institute is dedicated to primary care transformation through research and innovation, with a particular emphasis on the medically underserved. So in contrast to my esteemed colleagues on today's panel, I'm a public health epidemiologist and health services researcher by training. And I've titled my presentation, Approaching Primary Care's Role in Responding to COVID-19 Through a Health Equity Lens. See if I can advance my slides here. Seems like I'm having a little trouble with these slides. There we go. Okay. So the three overarching key takeaways that I hope you all can come away with from my presentation are as follows. So first, the current pandemic highlights and exacerbates persistent disparities, as well as the need to continue advancing the field's efforts in addressing social determinants of health, which I'll refer to as SDOH. Key takeaway number two, as the backbone of the nation's primary care system for the medically underserved for over 50 years, health centers play a key role in leading the response to COVID-19. My third and final key takeaway is that the current pandemic demonstrates the urgent need to strengthen the integration of primary care and public health. So the World Health Organization defines SDOH as the conditions in which people are born, grow, live, work, and age. They include intangible factors such as political, socioeconomic, and cultural constructs, as well as place-based conditions, including accessible healthcare and education systems, safe environmental conditions, well-designed neighborhoods, and availability of nutritious food. So the Bay Area Regional Health Inequities Initiative model shown here is a public health framework that shows how upstream inequities that can create unequal living conditions subsequently shape how we can approach our health behaviors, which lead to disparities downstream in disease, injury, and mortality. SDOH are an underlying cause of today's major societal health dilemmas, including obesity, heart disease, diabetes, and depression. That said, why is it relevant to talk about SDOH in the context of the current pandemic? So although COVID-19 does not discriminate along racial or ethnic lines, existing racial disparities and inequities in health outcomes, such as those shown here, may mean that the nation's response to preventing and mitigating its harms will not be felt equally in every community. Underlying chronic medical conditions may exacerbate the symptoms of COVID-19 and generally lead to worse patient outcomes. Because minorities have historically high rates of chronic conditions, these populations are at particular risk of being severely impacted by the pandemic. And additionally, people of color and immigrants are also less likely to be insured, which I know was brought up earlier in this panel, and many communities of color have shortages of quality healthcare providers, making it difficult to access appropriate and timely care. And lastly, a history of discrimination and marginalization has left some people of color distrustful of the medical system, making them less likely to seek out timely care. So while people of color are disproportionately impacted by underlying medical conditions that pose higher risk for severe illness from COVID-19, there is still no concerted effort to collect and publicly report on racial and ethnic information of those tested and affected by COVID-19. So last week, we celebrated both National Public Health Week and National Health Equity Week. There was an uptick in headlines highlighting racial and ethnic disparities in coronavirus cases from the few states that are collecting and reporting this information. So for example, New York City officials last week said Black and Latinx residents were dying at twice the rate of their white counterparts. In Chicago, more than 70% of virus-related fatalities were among African Americans, a percentage more than double their share of the population. And as noted in the March 27th Senate letter to HHS Secretary Azar, quote, without demographic data, policymakers and researchers will have no way to identify and address ongoing disparities and health inequities that risk accelerating the impact of the novel coronavirus and a respiratory disease it causes. So I created this hodgepodge of different social determinants of health to really illustrate that socioeconomic factors may further contribute to racial disparities in COVID-19 outcomes. The people most at risk tend to live in crowded quarters and take public transit to jobs deemed essential or impossible to do from work. Pre-existing health problems, as I noted earlier, are often related to living conditions, which can make the virus more likely to be fatal. People of color are more likely to work in low-wage jobs that cannot be done remotely and to have fewer financial resources to draw on in the event of health problems or economic disruption. According to the Census Bureau, poverty is also concentrated in communities of color, particularly among people with disabilities and the elderly. Moreover, unemployment, food insecurity, and unstable or substandard housing conditions may further perpetuate disparities in health outcomes for people infected by the coronavirus, particularly among low-income communities of color, which takes me to my second key takeaway. So health centers are consumer-driven, patient-centered organizations that serve as a comprehensive and cost-effective primary healthcare option for America's most underserved communities, including those that will be hardest hit by the health and social sequelae of COVID-19. America's health centers serve as the primary medical home for over 29 million people in more than 12,000 rural and urban communities across every state and territory. Most health center patients are either uninsured or publicly insured. are members of racial ethnic minority groups, and are low income. And with almost 10 million people applying for unemployment benefits in the last few weeks, an estimated 3.5 million people have lost employer-funded health insurance, according to a new study by the Economic Policy Institute. Subsequently, an overwhelming number of people are expected to sign up for Medicaid. So while health center patients have a higher prevalence of chronic medical conditions that are identified risk factors for COVID-19 than the national average, multiple independent studies, including one from the Kaiser Commission, Medicaid, and the uninsured shown here, have found that health centers perform better on ambulatory care and quality measures compared to private physicians and are narrowing health disparities. This discussion around the role of health centers in chronic disease management and prevention, especially during the current pandemic, relates to my third and final key takeaway. So during this speaker prep call, I was delighted to know I was joined by fellow optimists who are still critical of the current situation, but can still see the silver lining in all of this. So one of the major wins, potential wins with mixed feelings, as Ian noted, discussed here, is the role and expansion of telehealth. But I also want to highlight the opportunity for strengthening the relationship between primary care and public health. As the American Academy of Family Physicians noted, there is great overlap between the two fields in the care continuum: chronic disease management, SDOH, outbreak and disaster preparedness, care coordination, among others, all of which are highly relevant to the current pandemic. The 4 agency level recommendations that the IOM committee presented to HRSA and the CDC back in 2012 highlight the importance of structural changes for promoting integration of primary care and public health by identifying opportunities to coordinate funding streams and promoting data interoperability for shared use in assessments, intervention planning, and evaluation. Moreover, a retooled workforce is one of the most promising ways to model and encourage more complete integration. This retooling will require that primary care providers be educated about public health, that public health workers, like myself, be educated about primary care, and most importantly, that a new cadre of workers who can bridge both sectors in pursuit of improved population health be developed. While I'm not going to go into detail with this slide, I do want to note that the points raised by the AAFP and that there is a responsibility and role at every level to support integration of primary care and public health. Through integration, both sectors can increase their capacity to directly improve the health and healthcare of people and communities nationwide in such a way to produce a greater impact than any could achieve on its own. And by linking with other organizations, institutions, community resources, the leadership of primary care and public health can set the pace for interdisciplinary, intersectoral cooperation and help establish a national focus on the health of communities that will not only help us get through the current crisis, but also prepare us to be on a better path to health and well-being moving forward. So in sum, I want to leave you all with the 3 takeaways that I introduced at the beginning of my presentation. And again, while this is indeed a challenging and unprecedented time, it is also an opportunity for us to learn, grow, and improve our primary care system so as to better meet the needs of individual patients and communities. So please feel free to reach out to me with any questions or comments, and thank you all for your time.
Thank you, April Joy, and to all of the presenters for your thoughtful presentations. We have a number of questions, and I wanted to check. I know Mike Tuggy had a call right after this meeting. Are you still on the line, Mike?
Yes, I am.
Oh, can I pitch one quick question to you? And others may want to comment on it as well. Thank you. This is from Charlotte, North Carolina, and the question is around telehealth and what should be my strategy returning to, quote, normal in-person clinic volumes?
Yeah,
There may be a new normal.
we've been trying to inform our patients that the telehealth visits are a temporary thing because we're very frank about it, that the reimbursement is so low we couldn't keep our doors open. And I've had pretty positive responses that people understand that that would be a limiting factor. And I've said to a few patients, if you can help us advocate for getting telehealth done on an equity basis with regular visits, we would be happy to do it otherwise.
This is Ian Tong. I just want to add, I think that absolutely has to happen. I mean, this is a moment where we should not go back, and Mike shouldn't have to be, shouldn't have to even make that choice. I mean, I think it's a shame if our political leaders cannot help push this forward and keep some of these changes in place so that Mike's practice can get parity, and so that they can assign the right modality of care to the right patient at the right time.
I think we're all seeing that this horrible pandemic, it may become a positive disruptor that hopefully we don't slip back to old ways. Mike, you mentioned, and one of the participants raised a question about staff being furloughed, and I think it wasn't quite clear the context of what that meant. Could you clarify why that was happening? The individual said, I thought we didn't have enough staff and workforce to handle the pandemic. Maybe Mike had to leave, and I know that was the question. Mike, I know he has a call right at this very moment, so.
Yeah, I can try to address that one.
Sure. I think that Darilyn had a comment on this too. Go ahead, Ian.
Oh, that's right. Actually, yeah. Well, Darilyn, do you want to go first? That's right. I'd love to hear, and I can follow. But you'll probably.
Fine. I think that, I'm hearing from internists, and what we're seeing a unique phenomenon in internal medicine occur because internists are trained in outpatient, inpatient, and intensive care unit care of patients during their training. We're seeing some redeployment of our practitioners from the front lines of outpatient, sometimes into the inpatient setting or the emergency room setting, et cetera, by their health systems, which has been sort of a unique phenomenon that we have been seeing within internal medicine specifically. But I think what I take solace in is that we've seen rapid adaptation. There are a lot of obstacles here, clearly. Just the issue that we just discussed them for the last hour, but there are definitely a lot of issues that have been uncovered, but there's also been an unprecedented amount of people coordinating and pitching in together in this field in ways that we never saw before. So I think there's a lot, just as we have so many questions, I think we've unleashed many other questions. I don't think we're going to see a complete walking back from this, but as Dr. Tong has pointed out, these practices need to be made financially viable. They want to give patient-centered care. In some cases, that still means laying of hands, obviously, on the patient. But in other cases, it may mean converting those couple of those visits of the 4 or 5 that you would see a patient for every year into some type of virtual visit. This is, I think, it's sort of when you've seen one practice, you've seen one practice. And the challenges that we're seeing out there are a large variety, but we also see lots of opportunity as well. And I don't know what whether Dr. Tong wanted to follow up on that.
I'll just be brief. I think that was great. I just would add that many of my colleagues, this is why I had the mixed emotions in the beginning, because I do have colleagues in emergency room, ophthalmology, dermatology, many specialties that if they have non-essential duties, they may not be seeing the same patient volume. And so So I think Mike was probably referring to there's less revenue coming through the practice, and so therefore you may not be able to support, for instance, your diabetes educator if they're not able to get clinical visits virtually, and people are not coming into the clinic. So I don't know that was his scenario, but I think that's what he was referring to.
I think, Ian, that was what he was referring to. There were a couple of questions specific for you. One about what electronic health record system you use, and are the doctors that you all employ in an office, or are they working from home?
Great question. Most of our doctors do work from home. Some work from an office, but our platform enables them to work from home. And this is something that there's a long story and a short story. So I would encourage this person maybe to reach out to me if they want the long story. But the short version is that we built our own electronic medical record to really facilitate the connection, the video connection, and then the health record is built around the video connection. And so we see shorter visits as a result of that, I believe. Patients love the experience and feel that the doctor is providing them with compassionate care. And when we surveyed patients to see what did they love about it when they gave us a 5-star rating, we just had a paper accepted on this peer-reviewed paper. They mentioned it's all about the relationship. It's establishing rapport with the doctor. So that's what patients do love about it. But I just want to give you a couple of flavors of, we built our own EMR, though, is a direct question, and it functions very well.
Okay. Terrific. Thanks for that. And there was another very specific question. Do you all employ physician assistants?
We have not. We have employed non-physician healthcare clinicians. We have nurse practitioners and diabetes educators, and so I don't want to misspeak. We have pharmacists as well, but I don't think that we have any PAs as of yet. But certainly members of our care, that would be a good fit for members of our care team. And as we just to tie it in with the payment, once we have more capitated models or practice, sort of pay per patient models for primary care, then I think we can even, be more broad in our scope of the types of health professionals we employ.
Right. And I think I'm speaking for all of you, but please speak up if this is not true. One of the questions related to the licensure and all the regs that HHS and states have had in place about telehealth, and that they have now, over this short period of time, relaxed those. And most people, they're wondering whether this is just a short-term fix or whether it will be a long-term approach to healthcare delivery. And I think what I'm hearing from most of the field is we hope this has been a disruptor that we will see more of telehealth and that it will be paid for more appropriately. I think particularly for the federally qualified health centers and smaller practices, this is a major issue.
Bev, this is Darilyn. This is Darilyn. That's absolutely correct. I think the one thing, though, that we still are not seeing is that not all the commercial payers are paying parity levels for audio-only telephone calls that are being used in place of visits. And that's still an area that we all need to work together on. And I'm done. So whoever was going to speak, please take it from here.
That's a very important issue, I think, particularly for community health centers where there's a small margin and it's not adequate payment at all.
I would just add, I think that's right, and I agree. I was just gonna say I agree with Darilyn, and I think Mike articulated that for his practice, he would like to be able to choose the right modality for the patient and not have to take a financial hit, so to speak, in doing so. I think he doesn't want that to have to be a financial choice for his doctors. And I think if we can get to that point, that would be fantastic. And I just will make the caveat that for audio only, and I think this is true for most primary care doctors who would use telephone medicine, they're going to practice it with patients that are already in their practice. I do think there's some advantages to, I think video is great and we have great experience with it. And I think we have some good data that shows how it performs. And so I would just say it's great if we can open up the modalities and not have doctors have to choose based on, on compensation.
Wonderful. Well, thank you all. I want to thank the presenters for your thoughtful sharing, your insights, your experience and expertise. And I want to thank the attendees for their thoughtful questions and comments and for participating today. One of the, a comment for PCC, there was interest that the analysis of the quick survey, that's so important, and I hope people, all the clinicians on the call will go to the PCC website and fill it out. But they were asking for a regional and state analysis of these findings. As I mentioned before, the slides and the recording will be posted within 48 hours on the website, as well as some other resources related to COVID-19. And I hope that you have found this webinar useful today and that you will stay connected with the Primary Care Collaborative, such a wonderful organization. Thank you all so much for participating today.
Thanks for having me.